Guys, welcome to Clinical Unfiltered. We have a special guest. He's going to be doing multiple episodes with us. Just a wealth of knowledge and a cool dude, Dr. David Wong from Oklahoma, periodontist. I wanted to start doing a series on soft tissue grafts, and I mean, there's a lot of, interesting concepts and techniques, but I feel like there's no more special concept. I mean, the king of all potential techniques was pioneered by Dr. David Wong. So, our fearless leader of soft tissue grafting, David Wong, can you please describe your technique or take it away, however you would like to introduce the technique?
Yeah, for sure. So, the technique you're referring to is I call it the FATSAC, and
I too call it the fat sack.
I
Yeah.
think it's when I describe it to you, you're going to be like, that's most people will be like, I already do some version of the FATSAC. It's really nothing special at all.
This
And
is a drinking game, by the way. Every time we say fat sack, you have to drink.
yeah, sure, it would be a good drinking game. I I used it because in dentistry, there's everything's either named after the person who developed it, which I think is kind of arrogant. So I don't do that. Or two, it's got like a really long clinical sounding name. So a buddy of mine, Curry Levitt, he challenged me to come up with something that was kind of a little bit dirty, you know. So I used Fat Sack, and I was in an airport on my way back from Las Vegas, teaching one of our courses, and I had to like reverse engineer the acronym, FATSAC to make it fit this technique.
Oh, you reverse engineered. So it
Yeah,
came the
yeah,
yeah.
I had to come up with the
Did it have a K in there too at the end, or was it because it's FATSAC, right?
FATSAC. Yeah,
Yeah. Did it
yeah.
have a K originally and you just cut it
Didn't.
off? Or
I couldn't figure out how to get the K in there.
yeah, I wouldn't either. That's a knife. I don't know.
I stopped it, but essentially, what it was. It's a root coverage. It's a root coverage surgery. So it's ideal for covering exposed roots or exposed implant threads. And the reason it came about was it's basically, if you can imagine, the tunnel technique, where you make no incisions except for the sulcular ones, and just the traditional. It's a mixture of the tunnel technique, your regular envelope flap, and what Home is at A calls the Vista technique, right? So it's a
Right.
little bit of a combo of all three, and it came out just from how I do surgery every single day. I've been doing it for years, but I presented on it at the AAP when back when the AAP was online because of the pandemic,
Okay.
and
Gotcha.
I was on a
So you were
panel.
doing this technique prior to this is just how you did it.
Yeah, this is just how I
Okay.
named it. But
Gotcha. Okay.
I presented on this at the AAP, and the topic was: do you prefer to tunnel? Do you prefer to flap? What's the best thing? And there was three of us, and there was a guy from UCLA. There was, um, oh gosh, another woman. I can't remember her name right now. And then there was me, and one of them was pro flap, one of them was pro tunnel, and they asked me, David, what do you do? And I was like, well, you actually, I do a combination of everything, per case. I do a combination of everything. And they're like, well, why do you do that? And I was like, well, I mean, I have very average hands. I'm not a hand god. I don't have the skills that a lot of people do. I wish I did. And I'm not as smart as a lot of people are, but I know it works for me. And I know how to tunnel, but I can't get that damn graft through the
Right.
tunnel without
Yeah.
tearing stuff. I just don't have the hands for it. On the other
Yeah.
hand, I do recognize that you can't just flap stuff open, especially around implants, because that leads to poor results. So I was like, well, why don't you combine the two? And we'll talk about that here in
You
a
open
second.
up the gum tissue sometimes without a tunnel. Sometimes you make things worse than you started with.
Exactly.
Yeah,
And
especially if you
then
got if you
so
got the normal sausage fingers that I also too have.
yeah, so I
Yeah.
have the challenge of how do I get the graft in, but I also have the other challenge. What's the other challenge is how do I release the tissue? Once again, I'm not a hand god. I wish I was, but I developed. I I go through the freedom, and people are like, "Was it that just a Vista technique?" I'm like, "Yeah, it is, except I go through the freedom every single time." So that's why it's called the frenectomy, anterior tunnel sulcular access channel. So
Gotcha.
I can walk you through it
Yeah, yeah. I'll pull it
real
up.
quick.
I'll pull it up right now.
Yeah. So if you have recession like this guy does across 8 teeth in
There
the
you go, right at
front,
the bottom over here. Yeah. Okay. Yeah. Yeah.
you can absolutely, there's a bunch of different ways to do this, right? But because we're in the cosmetic zone, a lot of periodontists, especially, will say you should tunnel everything. Don't pop the papilla because you might lose the papilla. Blah 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 blah. Which I agree. But if you look over his canines, even the laterals and centrals, the tissue is pretty thin.
Right.
So even if you could release that flap, it's hard to graft to
I mean, it's
grab
a
your
thin.
graft
It's a
material, whether you
yeah. It's a
take it from
thin
the palate.
biotype. Those scare. Those are the scariest to manipulate the tissue. I mean, you're trying to
Yeah.
help. Not hurt.
Right. I mean,
But
how do you
man,
get that tissue through the sulcus, without tearing it? So that's why I was like, well, I'm going through the frenum because it's right in the middle, and I have instruments that are long enough to go. I can go all the way to the second premolars a lot of times with just this Pritchard elevator. All of us know how to use a Pritchard elevator. That's pretty easy. All of us know how to use the Mini Me or the Woodson. So that works really well. So if you go next slide, you can get that tissue released pretty easely. And then
okay.
the next slide I think shows like how much of the graft material you have, how you release that flap through the frenum.
Gotcha. You got a decent amount of tissue through there. So you're making a little hole there at the as the vestibule, and then you're applying the blade into that hole.
Yeah, so it goes through the frenum. So one thing here is I always make, because the frenum's all mucosa, you make a tiny little incision. It gets big, so
I
you want to
gotcha.
make sure you go kind of tiny because as you start stretching the hole, it gets kind of big. So
So you're doing some sharp, and then your kind of blunt dissection kind of takes over a little bit then too, huh?
yep, but you
Yeah.
have to release the tissue somehow. So I will actually introduce this 15 scalpel into either side of the frenum and release those periosteal fibers and get that really periosteal releasing incision like we would if we were to flap. So
Gotcha.
that's how I get access to release the tissue. But this is also going to be my access to introducing the graft. So by doing it this way, even somebody with average hands like myself can get this thing done pretty easily. So this is the product that's Alloderm. So you'll notice
Okay.
that we got two pieces. One's going to go in the left side, one's going to go into the right side, and
Gotcha. And
that's
just
where it
kind of
needs to go. So you can imagine trying to do this through the sulcus. It's just not practical
gotcha.
for me. But going through the frenum, easy peasy. So that's where the frenectomy anterior tunnel comes from. And then, of course, you just suture it up with. I like to use sling sutures, so I'm not trying to go over the papilla and possibly smashing them uh, whenever I can. And then you close up the frenum part with just chromic gut. But the white sutures that you see there, those are the PTFE sutures.
Gotcha. Do you always use a non-resorbable for those? Have you tried the monocryl for these cases?
No,
Never
I
practiced it.
have, but I prefer something a little softer and something that holds a knot a little bit better for me.
Gotcha.
But that's what
So,
it looks like at 2 weeks.
so this case, I mean, you really just made like an incision in that frenum area
Yeah,
and just tunneled both ends through there. No vertical release on any other end on this
nope,
case. On this case,
nope.
yeah. But
Yeah,
on that, I mean, well, there's some dramatic recession changes.
yeah. But that's how I do it. And the other thing is time. This takes like 30, 40 minutes versus an
Yeah.
hour and a half or whatever.
No, no. I mean, I was trained originally on doing like more like a Pat Allen tunneling technique where you just go
Yeah,
through the sulcus. And I mean, not only would it take forever because you're trying so hard not to break papillas, but you almost like need to get at weird angles to be able to get your instruments and really tunnel around all those different corners of the teeth. And I've started doing more of like your technique where I will make a vestibular incision
somewhere.
somewhere to get inside and start really releasing from there, and also
Right.
pass the graft through there. Um, and I feel like you have a version of this case where you did actually create
Yeah.
a vertical incision.
So where the vertical incisions come in, or the sulcular access, with or without the vertical incisions, those come in play because a lot of our patients will come in with class 5 composites,
Ah,
right, and
okay.
abfractions. So as you can see here on this slide,
Yeah.
if you look at the canines and the premolars, those are some pretty deep abfractions. They had composites at one point and they popped out,
Yeah.
or sometimes they have composites and they're leaking. But for me, tunneling was just not very practical because how do I get the composites all out and make sure that the root surface is smooth? So for me, I like to flap.
Right. And I feel like the indications for most of the times it is that. It's like these patients, I mean, if unless they were like coming from a right referral that was like, hey, um, you should cover it up with soft tissue rather than getting a class 5 filling. I mean, I do get a lot that had class 5 fillings have issues over and over and over again, and they were like, there has to be another way to
Yeah,
manage these, and then they come in, and so then I do feel like I have to manage a lot of restorations in areas that could be covered with soft tissue.
yeah,
Yeah. And this offers that flexibility because in tunneling, traditional tunneling, you really can't. It's hard.
it's hard.
Yeah.
Now there's a saying in perio that if they can put the fillings in without a flap, then you should be able to take them out without a flap. And I feel like that's false.
Yeah. I mean, I've seen so many when I've done that and I'm looking at like what looks like the base of the class 5 restoration, there's still some decay there or
Yeah,
something fishy there that I'm
or
not, you know.
they're using like flowable composite, which a lot of these guys do.
Yeah.
They can squirt it up under there pretty easily. But yeah, as you go through here, you'll notice that the anterior part where it's aesthetically critical, that's the tunnel. That's the
Right.
frenectomy anterior tunnel. The sulcular part helps you address the abfractions in the class 5 composites without having to overly compromise your aesthetics.
Yeah, I feel like that's like one of the keys that I've when it comes to connect to soft tissue grafting is as much as I can avoid disrupting papillas, I like it. I feel like it's
Yeah,
for the embetterment of the patient. It just takes more time and it's more technique sensitive.
right,
So I see what you did. You brought the best of both worlds together. You're like, hey,
right.
we'll try to keep papillas where we can, but I need to get access still. I need to get in there and actually get the job done. In a real world setting too,
Yeah,
like
yeah,
I
absolutely.
don't have 6 hours or 5 hours or 4 hours or 3 hours. I mean, I got an hour.
I have an hour.
Yeah, I got an
Exactly.
hour.
You have 1 hour to sedate your patient, get them numb, do
Alright,
all this, and get them out of the chair. I mean, could we do this 4 hours or what? Of course. If I'm teaching a resident or something, maybe we
right,
we do sit there. But yeah, private practice is a little different.
right.
So how do you
Um,
get all this material in there? It's
yeah.
easier for me to get all this material. This is perioderm from Dentsply, but it's just easier to go through the sulcus, on one end or the freedom on the other end. So it's just way easier.
I feel like that's another thing is that when people get into soft tissue grafting is that and especially if they look into tunneling because I mean trust me they're a sexy technique. I mean to be able to slide things underneath there and maintain the soft tissue, you'll
Yeah,
see some really cool things on Instagram. But when you actually start messing with this stuff and you don't want to take connective tissue, very first thing that happens when you try to tunnel, let's say you do a successful tunnel, you start trying to pass the graft and you're like, what the hell is happening? Why does it keep coming out? Where did it go? You
now
know,
there are some guys that can do it and make it look super easy.
right.
I'm not one of those guys.
Yeah. I'm right here with you. I got these Persian sausage fingers over here.
Yeah, I can't
That's
do
why
it.
I game technology. I was like, that's why. I was like, if I can get guides to help me with my implants, the better. You don't have to deal with these things over here, these toes that I got on my hand.
Yep.
Um, yeah, no. So I've done this too because I still like allografts. I think. I mean, we still haven't found a silver bullet that isn't soft, that isn't your palate yet. But um, I feel like for these recession cases that are diffuse on the upper, getting that tunnel access, I still like it. I need that extra help with vestibular incisions, and I feel like this is a good defined way. So you have a paper out on it,
I
right?
do.
Yeah,
I do. So it came out. I mean, it's not like it came out in like Journal of Periodontology or anything like that, but it was in
shoulda.
Inside Dentistry last year. It was in
Should,
Inside Dentistry last year, so it's in print.
yeah.
Unfortunately, they wouldn't print the word FATSAC, but they did print printed the whole thing out
The
after
whole
making me
title.
anterior tunnel. Yeah, they printed out the whole title.
The do you teach this technique?
I've never taught this technique.
No, never done.
I've presented on it a few times in at symposiums last year,
Yeah,
but I have not. I don't teach it.
like
There's
formally.
some things I think I like to keep to myself. I think
Okay.
FATSAC is one of them. Like I'll teach socket grafting. I'll teach connect. I'll teach free gingival grafts and stuff like that. But
Yeah.
stuff like this, I kind of just keep it to myself. When it comes to teaching like dentists, and then people like you can look at it and figure it out anyway. So it's yeah,
Yeah.
but I'll present on it.
So I'll do the only difference I think honestly I'm looking at this case. This is how I've like evolved to this. You know what it is? Honestly, and this is like a credit to you. I was always thinking about doing it this way. I think when I saw you accomplishing it this way and getting the results you were getting, I'm like, oh, I've been wanting to add like more vestibular incisions or get a little like combine the two. And
Yeah,
it pushed me to be like, okay, screw it. He's getting results. I should be able to do it too. So then like I said, I kind of know some of the fundamentals on how to do these procedures. So I brought it together too. And I'm pretty much approaching my cases like this. And I get the most success in my hands doing it this way.
yeah.
Because it does bring together, like I said, access and still maintaining as many papillas as possible for the aesthetics of it.
You keep the important papillas.
Right, right. I mean, so you get, I mean, I'm assuming you get some complications occasionally on these guys as well.
Patient complications, obviously you're going to get some bruising and swelling, on
Yeah.
occasion. So that's always a big deal. But that's, for ridge augmentations, for big
Right.
surgeries.
Well, I mean, I feel like when I did traditional tunneling, I was getting a lot more than doing like a free gingival graft. Just because you're creating that like internal space and closing it up and not having blood flow leak anywhere. It's all internal, so it's going to swell.
Right. Well, I mean, you got to think to yourself, like how many little blood vessels are really in that paper thin tissue, you know,
Okay.
to
Yeah.
feed that graft, like, and I think that's part of why people, that's one argument for tunneling is that I don't interrupt the blood supply because we didn't pop the papilla. But then you're like, nah, that tissue's so thin, and I just shoved a bunch of allograft in there,
Right.
is that good? Or even if you just use their own tissue, it has to die coming out of the palate before it revitalizes underneath the tissue. So you have, let's just say you have paper thin tissue that's less than a millimeter thick, but on the other hand, you have a 2 millimeter thick piece of palatal tissue or whatever you decide to use. The ratio isn't good,
Right.
So if you don't release that flap and create enough space under there,
The little blood vessel that could. Come on, buddy.
you get necrosis.
But I've had that. I've had like little papillas where I was like I push the limit. You know what? I mean, in the lowers, I run into that a lot in the anterior. So I don't like I'm a free
Oh, you
gingival
tried.
guy in the in
Oh,
the
you
lower. I don't know. I've had that issue on the lowers. Is those papillas are just so thin and small, and tissue's so thin in that area, and you got all these muscles pulling at a hanging piece of bone. Your
absolutely.
mandible.
For
So I'm a
the
free gingival guy in that area.
for the lower free gingival graft, and that's what
Right.
every single one of our friends would say too, except when
Yeah.
we post it on Instagram, then we do something different.
Right. The one time it worked
Yeah,
where it was yeah. So I was like, look, I did it. I did it. But yeah, no. So I mean, a lot of my tunneling cases that had issues were in residency. So I came out actually being like, screw this. And from a time standpoint, again, the upper, just the success was there on the upper. So I prefer to use tunneling or any kind of fancy um, soft tissue grafting is mainly on the upper for me.
well, there's a lot to it too. We talk about practice management and stuff too. Those tunneling instruments are a not cheap, and B don't last forever. So
Right.
whereas a 15
And you
blade
really
is
can't use it for much else either.
yeah,
Sometimes what I will do is like if it's very thin, because I mean again I've gotten burnt with some really thin tissues, even on the upper. I've been burnt a couple times where like
mhm,
you'll get a piece, and when you do that much grafting, sometimes it'll be a portion. I feel like that might have struggle, and it won't be the whole thing. Like you'll have a slight issue in one of the areas,
fortunately it's like that. Yeah.
yeah, and then you can kind of get rid of that area and come back to fight the battle another day. Um, I do. I don't. Do you try to manage like if you're having a complication, for example, in that patient that the canine area, maybe the allograft starts to extrude and it looks like green, brown,
Yeah, smells real bad and all that.
Yeah, you just put some barbecue sauce on it and put it back in, or
I always tell patients anytime we're doing, that many teeth, that it's not uncommon to have to do one little touch up.
right. It's like you would have had. I mean, you're lucky if you get one procedure out of this versus it being two procedures, which it probably could have been. If we didn't use that technique, it would have been like a 2-3 procedure thing. So I normally I almost open it up with like, hey, this is probably going to take us a couple steps. Although we try to get as much done of it in one shot. I actually take that route on the conversation with the patient. So when it works out with one, I'm like a freaking hero.
Yeah.
Rather than like, hey, yeah, it's that one area. Yeah, we'll need it. Well, that'll be for the second procedure.
Yep.
With that said, I mean, I don't on the upper. It is a once in a blue moon kind of situation. Whereas the lower, since I'm doing FGGs on that area, free gingival grafts, it's a lot more predictable. I mean, have you done free gingival grafts on the upper? Do you do them?
I just did one yesterday, actually.
Okay.
Um, we do them on occasion for implant revisions.
Okay.
Yeah, so sometimes when implants go, I do a lot of implant revision stuff for dentists and oral surgeons and other periodontists in town, to where you start operating on a single implant so many times, you'll lose that keratinized tissue. And so whether it's upper or lower, so I still go and do free gingival grafts up there if we need to. It's not my go-to,
Gotcha.
but we do them.
Gotcha. So you're let me ask you: are you still bringing connective tissue around implants, or are you gonna do the
I,
allografts more than like what's your go-to on those?
I never use an allograft around an implant. I
Okay.
used to do it because
Yeah.
I feel like I do have good enough hands to harvest connective tissue from anywhere in the mouth. I feel like, so I don't rely on allografts around implants. I never do it anymore. Haven't done it in at least
Gotcha.
15 years.
Interesting. Have you ever played with something like a fiber guide? Have you played like fiber guide or those other
I
like the I guess that's not a synthetic, it's more of a
Fiber guide
xenograft.
is it gets real thick and spongy.
Yeah.
I don't really like it that much. So what I use around implants, I would say the two techniques I employ the most are going to be either a tuberosity connective tissue graft.
Okay.
I use a lot
Gotcha.
of that because it's thick and dense. It doesn't go anywhere. If for single implants, if it's multiple implants, or if I really need to fill a big defect, I use that VIP CT graft quite a bit, and that's the vascularized interpositional
Where you
connective
kind
tissue
of roll it
grafting.
through the back end. That one
Yep.
I feel like I'm gonna do an episode on that one because that's a unique technique that I feel like a lot of people see on social media. I
Yeah.
feel like it does require. I mean, it's a little
That's
bit more
hard.
technique. Yeah, it's more of a technique sensitive procedure, but man, the results you can get from keeping that blood supply on that piece of tissue there are ridiculous. I mean, you want to talk about bulge, you know?
I get good results with
There's your
that.
next challenge. Make some kind of technique term and use the bulge in it somehow. Make it dirty, David. Make it
Actually,
dirty.
I already beat you to that last April. Last April,
Yeah.
Sean Young and he's an oral surgeon. He and I actually did a presentation in last April called "The Battle of the Bulge."
The Battle of the Bulge. Okay. There you
Yeah,
go. I mean, it
because
had to be done.
we
It
did it
had to.
already.
Yeah. It had to be done. Good. Good. If someone wanted to pick up, like, I mean, like you said, you're not teaching this specific technique, but soft tissue grafting, do you have like a recommended, hey, this is a good source,
Yeah. So
book, website?
if we're talking about soft tissue grafting, free gingival grafts, small little root coverage things, intro to allografts like alloderm or something like that. My buddy, Curry Levitt and I, that's also part of our course in Las Vegas that we do at his office twice a year. And that can be reached at www.orfoundation.org. And we only do it twice a year. It's like $1,800 for the weekend. We do the live surgery and pig jaw lab, suturing lab, and all that stuff. We do PRF as well, just to kind of. And
Okay.
I'm the tackling dummy on the PRF, so everybody's like drawing blood
Gotcha.
from me. The
The
records,
veins doing okay? You don't have a little
yeah, man.
scar?
The record's actually 11 sticks on me, so
Wow. Okay.
I go all in when I'm teaching courses. But if you guys want to get more information, go to orfoundation.org, or you can just message me on Instagram, and I can get you guys the details.
All right, man. Thank you for sharing with the audience the FATSAC. They are immensely better clinicians now because of knowing the potential of Dr. David Wong's FATSAC. Guys, again, remember we do this for the love and passion of dentistry. No money is coming in from doing these things, these episodes. So please like, follow, share, tell a friend, bring your grandma. I think she would love this episode. Um, and thank you guys very much for listening. And thank you, Dr. David Wong.
Sausha, thanks so much for having me. Always good to chat with you, bro.